insulin stimulates the sympathetic nervous system, and the sympathetic activation increases insulin resistance, and therefore it increases the insulin level. Just to mention one, white coat hypertension is not an innocent clinical condition, and unfortunately, this has to be said and said and said again.
Dr. Giuseppe Mancia is a professor in medicine and world-leading expert in hypertension, white coat syndrome, and sympathetic nervous system. My first question to you is that hypertension is a very complicated disease. So many organs involved, so many hormones. From your decade of research and experience, what is the best explanation for hypertension, and what are some of the mechanisms that are overlooked?
Well, the current idea is that hypertension is a multifactorial condition. There are very many systems controlling the cardiovascular system and blood pressure, which are activated in hypertension. And for some of them, there is a sort of a positive feedback interaction. For example, insulin stimulates the sympathetic nervous system, and the sympathetic activation increases insulin resistance, and therefore it increases the insulin level, just to mention one. But another interaction is between the renin-angiotensin-aldosterone system and the sympathetic nervous system. Sympathetic activation is responsible for production of renin from the juxtaglomerular cells, and in turn, angiotensin II has a stimulating effect on the sympathetic activity, both at the level of the brain and at the peripheral nerve terminations. So you see, it's difficult to identify, except for a small number of conditions. Secondary hypertension is different to identify specific mechanisms responsible for the development of hypertension. This has an important practical implication, and this is that efficacy of treatment is largely related to combination of drugs with different mechanisms. This is, in a way, a reflection of the multifactorial conditions that are responsible for the generation of a high blood pressure.
You have done a lot of work, mainly the most famous is the Pamela study, to establish that white coat hypertension is not a benign condition. Could you talk to us about white coat syndrome and what is the reason or mechanism behind white coat syndrome, if we know a reason for it?
And this is a very interesting question to discuss, because white coat hypertension is extremely common. Maybe 30–40% of the hypertensive patients do have white coat hypertension. In the elderly, even more than 50%. In the Hypertension trial in people age more than 80 years, more than 50% of the patients had white coat hypertension. Yes, what you say is absolutely true. White coat hypertension is not an innocent clinical condition, and unfortunately, this has to be said and said and said again, because many people believe that diagnosis an individual as having white coat hypertension means that he or she has no risk. This is not true. For example, subclinical organ damage is more common in white coat hypertension than in normotension. The risk of developing over the years sustained hypertension or diabetes or new organ damage is greater in white coat hypertension than in normotension. And the risk of having cardiovascular events over the years, we did the study having more than 15 years follow-up in the patients. Well, the risk of having hard clinical outcomes was definitely greater in white coat hypertension than in normotension, although being less than that of sustained hypertension. So it's a condition which is in between true normotension and true hypertension. Why this is so? Well, there are several factors that can explain this. For example, one of them is that although by definition out of office blood pressure is normal in white coat hypertension, it is less normal than in truly normal individuals. We define it as normal, but it's still 3 or 4 millimeter of mercury ambulatory blood pressure higher than in normotensive subjects. And home blood pressure is 6, 7, 8 millimeter of mercury higher in white coat hypertension than in normotension, although remaining below the so-called threshold for hypertension. And then, for example, nocturnal hypertension is also more common in white coat hypertension than in normotension. The lipid profile is more commonly abnormal in white coat hypertension than in normotension. So there are many conditions that explain why white coat hypertension is not an innocent condition. What is the whole as far as knowledge is concerned in this area? Well, there is an important missing information, and this is that once we have identified white coat hypertension and diagnose it, the problem is what do we do? Do we treat these patients or not? And the answer to this is we do not know, because there are no trials exploring whether lowering office blood pressure in white coat hypertension is associated with a reduction of cardiovascular events. So guidelines, have to deal with this difficult problem, and they have a sort of a compromise. They say, well, if patients have organ damage, then you may consider treatment. If patients have just pure white coat hypertension, follow it more closely, but do not treat. But this is based on clinical considerations, not on evidence.
Do we understand the mechanism behind white coat syndrome? Is it related to the sympathetic nervous system? Is it related to the amygdala, to the afferent vagus nerve, to the renin-angiotensin-aldosterone system? Or what is the reason behind white coat hypertension?
Well, it's not clear. One of the reasons for sure is reactivity to the doctor's visit. That could be one of the reasons, but not the only reason, because we do have not really close correlation between patient's reaction to the emotional stress of the doctor visit and the existence of white coat hypertension. My colleague, Professor Grassi, working in Milan, has shown several years ago that sympathetic activity, as measured by microneurography, that is directly quantifying the number of sympathetic bursts in humans at the peroneal nerve level, well, sympathetic activity is greater in white coat hypertensive subjects than in normotensive subjects. So the cause of white coat hypertension is not limited to the mechanism of the blood pressure increase during the doctor visit, but it is something different and more systemic.
Mm-hmm. Do we have understanding why oversympathetic nervous system is in some people, and why would some people respond to stress? Their blood pressure would spike and respond to stress than others?
No, I don't think that this is known, unfortunately. But we do know that laboratory stressors, for example, say mental exercise, isometric exercise, for example, hand grip, or dynamic exercise, for example, treadmill, all laboratory maneuvers that increase blood pressure, they do not have a correlation to one another. We did these studies many years ago when we were doing intra-arterial ambulatory blood pressure monitoring, so we could do a number of things which are normally unavailable to current research because of inability to measure blood pressure intra-arterially in physiological conditions. Well, there was absolutely no correlation between response to one laboratory stressor and response to another laboratory stressor. So it is very difficult, therefore, to give a general meaning to responses to stressors in subjects and approach the problem you mentioned, that is, what is the nature behind the responses to stress in a way. But one other thing we found is that responses to laboratory stressors do not correlate with blood pressure variability throughout the 24 hours. You see, this is another puzzling thing. I mean, you can be hyperreactor to one stressors, but not to the other stressors, and not to overall blood pressure variability, which is probably generated by a number of factors well beyond just the emotional response to stimuli.
And the overactive sympathetic nervous system is a centric problem, or do we know any pathophysiology about it, or what causes it?
Well, one central factors are certainly involved, for sure, but there can be other mechanisms. One of the possible mechanisms, for example, abnormalities of the baroreflex. Mm-hmm. Baroreflex normally keep sympathetic activity down. People with denervation of the carotid and aortic baroreceptors do have sympathetic activation because these inhibitory mechanisms are not functioning. However, this is an acute mechanism in a way. If we keep animals with some aortic denervation and leave them free, unrestrained, over the months, blood pressure goes down and the baroreceptor reflex reset in a way down what is left from the baroreceptor reflex. So the current view is more than abnormalities in the baroreflex may be responsible for a baroreceptor reflex resetting, but not so much for the level of blood pressure and sympathetic activity persistently over the day and night in a way. We're dealing with a complicated factor, I'm afraid, and I cannot give you a conclusive response to this. But certainly central factors are involved. There is a hyperreaction to emotional stimuli. Certainly they are involved. Mm-hmm. Remember that hyperactivity of central factors, they can silence the baroreflex. I remember many years ago, in the 70s, we did a study on few people involved. There were the same investigators, myself included, was involved in this story. And this was to see what was the response to hand grip exercise, the pressure response, modified by central factors. That is the brain. That is the will of the investigators to inhibit the response. And amazingly, there was the capability of influencing the response by just thinking of influencing the response. So the brain is involved in modifying a number of more peripheral mechanisms in many ways. But I think going to the practice, I think without the mechanisms, there is no question that in hypertension, sympathetic activity is increased. Mm-hmm. And the increase can be visible already in the very early phases. For example, children of two hypertensive parents, not children, young people from two hypertensive parents, even if they are normotensive, they do have an increased sympathetic activity. And then the increase in sympathetic activity is further enhanced as hypertension progresses. The severity of hypertension is associated with the increase in sympathetic activity, and the highest level we have found is in resistant hypertensive patients.
Mhm. Do we have any understanding about the Baroreflex, what the pathophysiology is behind it, or understanding how it contributes to sympathetic nervous system? Is it because of inflammation, because of genetics, because of any known factors?
Well, first of all, no question that afferent fibers from carotid sinus and the aortic arc, they do have a strong inhibitory influence on reflexly on sympathetic activity. That's for sure. I mean, if they are cut, the sympathetic activity goes up and blood pressure goes up markedly. So the main action of the baroreflex is to provide homeostatic mechanisms again to marked variations in blood pressure. There are some beautiful experiments on this. One is in dogs, and the other one is in cats by our group in Milan. And then the other problem is that the baroreflex interacts very markedly with other reflexes. For example, the chemoreflex. Chemoreflex is an excitatory activity. If I stimulate the chemoreceptors in the carotid sinus by hypoxia, ischemic hypoxia, for example, well, there is a striking increase in blood pressure and generalized vasoconstriction, plus bradycardia. This is anomalous, but this is what happens. Well, if I do this stimulation at a high baroreceptor levels, that is in isolated carotid sinuses, I perfuse the carotid sinuses by anoxic blood, and in the meantime, keep the carotid sinus pressure at 200 millimeter mercury. That is maximal baroreceptor stimulation. What happens? Chemoreceptors do absolutely nothing. That is, they lose their control of the circulation, presumably because they are inhibited at the central level. Baroreceptor influences are capable of silencing the central influence of the chemoreceptor reflexes. Now, more recently, this was found to give an explanation to the fact why in resistant hypertension in humans, when we stimulate electrically the baroreceptor afferents, and you see that this one is one of the tools which is used in emergency to reduce blood pressure, resistant blood pressure, or in emergency conditions in which blood pressure can be markedly elevated. Well, this can be explained because electrical stimulation of the baroreflexes can prevent the simultaneous vasoconstrictor effect of the chemoreceptors. Otherwise, you wouldn't know, because the electrical stimulation of the afferent fiber stimulates both chemoreceptors and baroreceptors. But what prevails is the baroreceptor stimulation.
Do you believe that white coat syndrome also is not just in the hospital settings, it's also from day to day, from while working, while driving, while dealing with everyday stressors?
Absolutely. It's not only in hospital. I mean, I mentioned this 30-40% prevalence of white coat hypertension refers to the general population, not to the hospitalized patients. And what we look at this in detail when we were doing intra-arterial blood pressure monitoring, and what we asked physicians was to go and measure blood pressure when blood pressure was measured intra-arterially in the patients for 48 hours. And what we found was that the reaction of the patients to the doctor visit was very common, sometimes a striking effect. In one patient, I remember, as the doctor entered the patient's room, and the patient had an intra-arterial line, of course. In the intra-arterial line of the patient, there was an 80 millimeter of mercury increase in blood pressure. And I'm not talking of hospital. I'm talking of people in their
outpatient.
Yeah, outpatient. And then the visits were repeated, and up to 4 visits, the response was more or less the same. So there was you may think that the second time, they adapt to the blood pressure measuring by the doctor. But as far as we can see, this stress-related emotional response by the patient was preserved.
When the blood pressure initial reading is very high and then the second one comes normal, it fluctuates so much variability between few minutes of reading. Is that also related to the same mechanism?
Yes, it is related to the emotional effect of blood pressure measurement. We could see in the intra-arterial tracing very clearly. The peak response came after between 30 seconds or 1.5 minutes after the beginning of the visit. And then there was a gradual reduction so that at the end of the 15-minute visit, maybe 1/3 of the pressure effect was still there.
Mm-hmm.
And then we look in another study in which there was a randomized measurement of blood pressure by a doctor and a nurse in the same patients, 30 patients, I remember. First, 15 times the doctor visit was the first, and then the nurse's visit, and in the other 15 times the sequence was reversed. And no question that the blood pressure rise was less with the nurses than with the doctor, about half.
Do we know at which level do we get endothelial damage or organ damage? At which level of spike in blood pressure?
No, I do not know, but of course it is very well known that endothelial function is adversely affected by a blood pressure elevation. I think there is also evidence that this adverse effect occurs rather early in the course of hypertension, but I don't think that the details go much farther than this.
At which level do you start to think that maybe it's wise to go more aggressively with these people with white coat syndrome or people who have spike to blood pressure to stressor? At which level do you start to think maybe pharmacological therapy is justified at those cases? Is there a threshold or a level where you get more aggressive than conservative to wait till an organ damage occurs?
No clue about this. As I mentioned before, guidelines limit themselves to the recommendation to identify, if possible, whether a patient has white coat hypertension, because, of course, this means a greater risk than in normotensive patients. But then as far as treatment is concerned, it's rather vague because of the absence of evidence. And therefore, what I say is to follow the patient more closely and to try to give antihypertensive drugs if there is organ damage or a number of other risk factors, you see. But this is based on what we can consider medical common sense, but no more than common sense. I would add 2 considerations on this very difficult aspect of medicine. White coat hypertension was common, for sure, in many trials which showed the beneficial effect of treatment. In the Hypertension trial, for example, we know that white coat hypertension had a prevalence of more than 50%. And in Hypertension, reduction in blood pressure was associated with a clear-cut reduction of cardiovascular events, particularly heart failure, but also stroke. Well, my question is, would this be possible if white coat hypertensive patients did not participate in the benefit? Being so common, you see. And this is an argument in favor of treating white coat hypertensive patients. Of course, the best solution would be to have a trial in which we can recruit white coat hypertensive patients and have a control group without treatment and a treated group. The second point is more delicate, and this is suppose that we decide in a way to follow the guidelines and we do not treat white coat hypertensive individual. And suppose that, unfortunately, this patient has a stroke. Now, this could pose a legal problem because lawyers could say, well, why didn't you treat this patient when there is evidence from trials on more than 500,000 patients that lowering office blood pressure is associated with protection? A big protection against stroke. So why did you avoid treating? And then we have to say, well, because, white coat hypertension guidelines say that we shouldn't treat them. But I think that would be a very difficult case to be resolved and a big problem for the doctor.
Believe that an agent that works on the sympathetic nervous system
Yes.
lowers the activity of the sympathetic nervous system. A calming agent would lower the sympathetic nervous system, and that will lead to lower blood pressure reading?
No question that if we give drugs acting against the sympathetic nervous system, this is responsible for blood pressure reduction. We can have a number of examples. For example, in the past, this is part of history now, but sympatholytic drugs, were widely used. Guanetidine, for example, to reduce blood pressure. Ganglion blockers were widely used to reduce blood pressure. Beta blockers today, they work through reduction of sympathetic activity, which in turn means also reduction in the renin-angiotensin system activity, because reducing sympathetic activity reduces secretion of renin from the juxtaglomerular cells. But the primary factor is reduction in sympathetic activity. This is widely known. But even alpha blockers, if we give alpha blockers, blood pressure is reduced. One of the problems has been, as far as alpha blockers are concerned, that development of new alpha blockers was stopped because of the unfortunate results of a major trial in hypertension. This was all-het. In all-het, there were 4 different groups treated. One of them was treated with doxazosine, which is an alpha blocker, long-acting alpha blocker. Another with diuretic and so forth. And the doxazosine group was stopped after few years, 2 or 3 years, I do not remember exactly, because compared to diuretic, heart failure, the incidence of heart failure was doubled compared to diuretic. And of course, this has had such a big effect on the thinking of investigators and clinicians in the area of hypertension that nobody really took the risk to work and develop other alpha blockers. Now we know that probably there was a problem in all-het data, and the problem was that the patients in all-het, before the beginning of the study, were all under diuretic. Most of them, the vast majority of them, was under diuretic treatment. Okay. And of course, diuretic treatment was stopped to randomize the doxazosine arm. Since they were high-risk patients, the reasoning is that probably many of them had, a number of them had heart failure, which was masked by diuretic treatment. And when diuretics were stopped, heart failure appeared, you see. So it was not doxazosine, but it was, in a way, a sort of an artifact due to stopping a drug masking the symptoms of heart failure, which was the diuretic. And this hypothesis is, in a way, supported by the fact that despite the much greater incidence of heart failure in the doxazosine group, there was very little difference in mortality in these patients with heart failure. So it was a heart failure which didn't have the usual high risk of death, which normally heart failure has. But anyway, the long-term effect of this study was that alpha blockers are not used in heart failure. Alpha blockers are used in hypertension to lower blood pressure, but only as a second or third or fourth drug, not really one of the major antihypertensive drugs.
Is there any agent that lowers the sympathetic nervous system but does not cause bradycardia? So if someone has bradycardia and white coat syndrome due to being an athlete.
Yes, of course. And the example is, again, doxazosine, alpha blockers. Alpha blockers do cause tachycardia because of reflex, baroreceptor reflex mechanism. Reduction in blood pressure, and the baroreflex works to increase heart rate. So they were normally given with a beta blocker.
And there is another agent called riflexudine, I believe. I don't recall the name exactly now, that has minimal effect on the heart rate and lowers the sympathetic nervous system.
Yes, but for example, there are also the so-called central agents. One of them was widely used in the past, and this was methyl dopa, but even clonidine is a central agent with a clear-cut anti-blood pressure lowering effect. It's still used in hypertensive emergencies today, like methyl dopa. Methyl dopa is still one important drug to treat hypertension in pregnancy. And both of them do have a bradycardic effect, but this is a very, very small, could be 2 or 3 beats per minute, not more than this. Certainly much smaller than what you can see with beta blockers.
And there is one agent, let me just... Rilmenidine.
Rilmenidine. Yes, this is a central agent and working through mechanisms somewhat different from those of methyl dopa and clonidine, through blockade or stimulation, I do not remember exactly now, of receptors which are different from the other two drugs, but still belonging to the group of central agents and more or less with similar effects as methyl dopa and clonidine.
Bradycardia, or very less minimal than the others?
No, it's more or less small bradycardic effect. I mean, but really the reduction in heart rate is very small. I mean, reduction in heart rate when it is limited to 7-8 beats per minute. This is more or less the effect of beta blockers. Could be 10 beats per minute, but normally we are in this range. This does not represent a disadvantage, okay? Because heart rate is a very clear independent cardiovascular risk factor, particularly above 80 beats per minute. So lowering heart rate is not regarded as an adverse effect in general. There has been a paper published just a few days ago in the European Heart Journal. Is a meta-analysis of trials having a reduction in heart rate, more than 2 beats per minute, very huge, 74 trials. I'm a co-author.
No.
And it shows that on average, a reduction of heart rate of 80 beats per minute is associated with reduction of cardiovascular events. And of course, this study was done by adjusting for blood pressure changes. And it was also done using trials with negligible effects on blood pressure.
The challenge becomes when someone is bradycardic and their heart rate is around 60 if
Of
they're
course,
athletes,
of course.
then that would be
right. I think in this meta-analysis, for example, what was found was that the advantage was visible, particularly if heart rate remained between during treatment, 65 to 70 beats per minute. Below 65, the advantage was less clear. You see, so I think the point you made is a good point. I think the advantage of reducing heart rate may be less in the below 60 beats per minute. Maybe the benefit in this case is not so clear, but still, if I give a beta blocker, I'm looking at other types of benefits, for example, reduction of sympathetic activity and the blood pressure reduction. From the fact that sympathetic nerve activity can be reduced also by blockers of the renin-angiotensin system, okay, because of elimination of the sympathoactivating influence of angiotensin 2.
Like ACE and ARABs? Like ACE inhibitor and ARABs?
ACE inhibitors or ARB, more or less, they have the same influence, although the evidence is stronger for ACE inhibitors. For example, we've seen this in humans in which we measure coronary blood flow and intra-arterial blood pressure. They were on the hemodynamic table. And we look at the pressure response to a stressor before and after intracoronary administration of minute doses of angiotensin inhibitor, okay? And the pressure response to sympathetic activation, there is coronary vasoconstriction. These were all, of course, patients with no coronary problems. Of course, they were normal. The vasoconstrictor, sympathetic induced vasoconstriction was markedly reduced by minute dose of ACE inhibitors in the coronary arteries.
Very interesting.
This is an example of interaction.
Do you think the same benefit can come from oral ACE inhibitor or ARAB, that it will lower the sympathetic nervous system and the blood pressure?
I think so, yes.
If you would do a clinical trial for white coat syndrome and you choose an agent to put in the group, is there a specific agent would you think will work very well in those groups?
No, I think I would use treatment which is recommended by guidelines in a way. Without any, the problem would be to have a common type of treatment, which is a guidelines combination treatment for sure, and then versus a placebo group or white coat hypertensive individuals. This trial has never been done, and I'm afraid it will be difficult to do a study like this because since risk of events is quite low, less than in true hypertension, it will have to be a very, very large trial, big trial, in order to reach the statistical power good enough to support the significance of a difference. And I think this will be very, very difficult to be done. So we are confined to this very ambiguous position that we are advised to try to identify white coat hypertension and the contrary, that is masked hypertension. But in the end, then we do not have any help in terms of what we shall then do as far as treatment is concerned.
Yeah, and the challenge also that for white coat hypertension, it will take them much more longer to get an organ damage or to establish results then
Exactly like this. It will have to be a very large and very long study.
yes.
And now we know that one of the problems of increasing the length, the duration of the study beyond the 4 or 5 years is that there is an exponential increase in the patients lost to follow-up, patients that say, stop, I do not continue. Sorry for you, but I do not continue. And this, of course, weakens very much the scientific basis of the study. This is the reason why one of the big problems of antihypertensive treatment today is that our evidence, trial-based evidence, is from studies of a 5-6 year duration.
Mm-hmm.
Based on this evidence, we advise our patients to take drugs for the lifetime. Okay? But the remaining evidence is based on observational studies, not on trial.
And in your experience, when you decide to treat someone with white coat hypertension, is there a specific agent you would go for, or you would just follow the guideline, whatever? What I'm trying to ask is, do you try to find an agent that works in the sympathetic nervous system on top of hypertension, or you just follow normally what the guideline says? And do you think there is an advantage?
I have to say, I mean, theoretically, because of increase in sympathetic activity, beta blockers could be one of the drugs used. But I have to say that I do not pay too much attention to this. If I decide to treat a white coat hypertensive patients, individual, I think I just try to lower office blood pressure using, one of the 5 major drugs which are recommended by guidelines.
Exercise is very good for hypertension on the long run, and but sometimes when we do like the treadmill testing and so on, when you do exercise, the blood pressure do spike very high. Does that spike in blood pressure, if it goes very high up to 180 or 200, harmful?
We don't know. We don't know because, of course, it's difficult to have enough outcomes to decide that this is dangerous. I mean, based on common sense, of course, one should think that there's something to be avoided. One other thing consideration is that patients showing a very marked pressure response to treadmill exercise have a greater risk of having masked hypertension. So the next thing to do is to have a 24-hour ambulatory blood pressure monitoring in order to see whether these patients do have masked hypertension, because this means an increased risk. Not at the same level as the risk of true hypertension, but definitely an increased risk. But then, of course, the problem is more or less the same as the one for white coat hypertension. That is, do we treat this patient with masked hypertension then? And guidelines do not take a definite position. I think they again say that if the patient has organ damage, and so then lowering out of office blood pressure should be considered.
Yes. And also
I think this is probably the best, the most, the best recommendation we can give.
Mm-hmm. And sometimes the diagnosis of hypertension is easy to establish, but sometimes it's very complicated. So sometimes someone would visit the office and will have hypertension, and another visit will not have, but then you will do the 24-hour blood pressure and he will have normal to normal reading. How do you deal with such cases?
Well, which blood pressure shall we use to diagnose hypertension? Okay. Now, according to the guidelines of the European Society of Hypertension, office blood pressure is still the reference blood pressure, because all epidemiological data and trial data we have and value the threshold for treatment and the target for treatment, they come from office blood pressure. We have no trials on ambulatory blood pressure. Okay. And then, of course, we say that ambulatory blood pressure is a source of important information. One of them is to identify phenotypes such as white coat and mast hypertension. So anytime this is feasible, data should come from ambulatory blood pressure, should be obtained. But office blood pressure remains the reference blood pressure. So diagnosis of hypertension and the threshold value at which to start drug treatment should remain office blood pressure. This is according to the guidelines of the European Society of Hypertension. The guidelines of the European Society of Cardiology take a somewhat different position. They say that diagnosis of hypertension should take into consideration ambulatory or home blood pressure. But there is a little bit of a contradiction then, because classification of blood pressure into non-elevated, elevated blood pressure and hypertension is based on office blood pressure. And the threshold and target for treatment are based on office blood pressure. So in a way, in practice, even these guidelines give preference to office blood pressure, in my opinion.
Do you rely on the first reading of blood pressure? If someone is high, then you wait 2 to 3 minutes and then measure it again. So do you rely on the initial reading or multiple readings and you average it out? Usually when the patient comes in the beginning, the first reading, especially if he didn't sit down, that in many people initially will be high.
First of all, let me say there have been many studies looking at whether variability of blood pressure within a visit has a clinical meaning. And the answer from most studies is no. Okay. Anyway, it is true what you say. That is, the first reading tend to be higher. And so guidelines, although somewhat arbitrarily, what they say is you should have 3 measurements. The first measurement 5 minutes after the beginning of the visits, and then other 2 measurements at 1-2 minutes interval, and then take away the first value and make the average of the last 2. This is what is recommended. I think most guidelines do this, and I think it is important that guidelines agree on this because of the possibility to compare data. Of course, the other problem is that particularly in grade 1 and grade 2 hypertension, you should repeat the visit. Just do not take the value at the first visit as diagnostic, but repeat the visit after few weeks, other 2 visits. So, I mean, in the end, the judgment should come from more than 1 visit, except if blood pressure is extremely high or you have evidence of hypertension-mediated organ damage. Then you can save time in a way and rely on the value of the initial visit or maybe 2 visits, in order to have a regular visit with the regular blood pressure measurements, because in hospital, values can be completely different.
Tell us, please, a little bit about the Pamela study that you have followed the I think it was over 2,000 patients for 10 years.
Yeah. It was a branch of the MONICA study by the WHO, and it was a sample representative of the population of a town in the outskirts of Milan, which was Monza, and it was representative for age, sex, education, a number of things. And the initial purpose was to be able to calculate from a proper sample normality of ambulatory blood pressure value, because at that time, normal ambulatory blood pressure was calculated from people coming to visit and found to have not an elevated ambulatory blood pressure, but if they came to visit, there was something suspicious about them. So it was not really a good a good group to make a comparison from. And so we calculated the normality of ambulatory blood pressure based on an unbiased population sample, okay, from the population. It was the first goal, but since the study had a number of measurements, lipid profile, glucose, many things, uric acid, of course, renal function, and each individual of the study had an echocardiogram. This was, of course, a big effort, but that's why we have been able to study a number of things, including metabolic syndrome, including many other things. And then the other thing which has characterized the Pamela study has been that we restudied the same sample 10 years later. This is the weak point of studies on ambulatory blood pressure elsewhere in the world, that they have just one measurement of ambulatory blood pressure. Then a long follow-up of 15 years in which no data have been collected. So you can imagine, how many changes occurred during this time. In Pamela, there was a second set of measurements, the same procedure, 10 years later. And then there was a third one, 25 years later. This was completed a few years ago. So we now have a quarter of a century follow-up. Of course, in the meantime, many patients died, but we were able then to have long follow-up of our studies with quite a high number of outcomes. In the recent follow-up, I think we had quite a large number of deaths as well.
And were you following them up between the 10 years or only just initially and after?
No, this was impossible. I mean, this is one of the reasons why studies with ambulatory blood pressure and home blood pressure have not been done with serial measurements like the Framingham study. Framingham study was perfect because in all individuals from the Framingham town, 5,000 patients, not a big study, 5,000, but the procedure was perfect because they had the serial measurements every 2 years, if I remember correctly. And this has been impossible for studies with ambulatory or home blood pressure because inability to have compliance by the individuals if this procedure was used. But at least, having data 10 years later allow us, for example, to see that in white coat and masked hypertension, the risk of diabetes and the risk of true hypertension was greater than in control subjects.
Do you believe that any of the smart devices that are now they're coming up with smart devices to monitor the blood pressure, do you think those will have value in measuring blood pressure? The continuous measurement.
A continuous measurement. Well, I think they should be validated, first of all, and most of them are not. And secondly, I think conditions have to be standardized. Really, at the moment, I think it's a rather chaotic situation with these app devices and things like this. And I'm afraid that there will be serious disadvantages as far as solidity of the diagnosis of hypertension and the precise assessment of the effect of treatment. So I think potentially they can help, but they should be validated, and we should find a way of standardizing this approach.
Are there any upcoming, other than the 24-hour blood pressure machine devices, that will be continuous and without the cuff inflation and deflation, and it will be...
Yeah, the cuffless devices.
Yes.
Yeah, this is quite promising, seems to me, because, of course, inflating the cuff can be disturbing.
Yes, especially in sleep.
Annoying to the patient. particularly
In sleep.
during the night, but I'm not sure that this problem, maybe it has been inflated a bit too much, because when we were doing intra-arterial ambulatory blood pressure, one study we did was to have non-invasive cuff blood pressure, automatic blood pressure on one arm, intra-arterial on the other arm, and we prolonged the intra-arterial recording for 48 hours. And 24 hours were done concomitantly with the non-invasive automatic ambulatory and 24 hours without. And the fall in blood pressure at night was almost superimposable in the two conditions. So patients could sleep well anyway.
Yes.
But of course, this was the case in our 20 patients. Maybe some patients really, they become sleepless if the cuff inflates regularly and periodically. So I think because of this, cuffless devices, represent a potential advantage, and I think they should be seriously validated. But if this is done, I think it could be a progress.
So many patients, when they increase their intake of potassium and reduce the sodium, that helps in blood pressure control.
Increasing potassium has an antihypertensive effect for sure. And not only an antihypertensive effect, but a protective effect on vital organ structure and function. This has been discovered a long time ago by a famous American investigators from Minnesota. I can't remember the name now, but it was a very important scientist, and he showed wonderful evidence that this is the case. And for this reason, now increase in potassium intake is one of the non-pharmacological based treatment of hypertension. Mm-hmm. In practice, it means eat vegetables as much as you can.
Okay, so Professor Mancia, it's been a huge honor to speak to you, and thank you so much for all of this valuable information. And thank you for all of the work and research you have done over the years, including the Pamela study, the sympathetic nervous system, on all of the great work you do.
Thank you very much.
Thank you.
Bye.
Thank you so much.
Bye.
Take care. Bye-bye.
Bye.